My dear students, unfortunately, we do not have any classes because of the corona. Anyway, let us start with the first topic after the corona, which is the tonsils. The tonsils is an important topic in there. It can be asked as a long question. Now, what is the definition of a tonsil? It's a subepithelial aggregation of a lymphoid tissue. Subepithelial aggregation of a lymphoid tissue and forms the part of a Walde's ring. What is this Walde's ring? We have got the inner Walde's ring and outer Walde's ring. The inner Walde's ring is formed by the pharyngeal tonsils, the partial tonsils, adenoid and the palatine tonsils. Whereas the outer Walde's ring is formed by all the circular group of lymph nodes, the submandibular, preauricular, postauricular and occipital group of lymph nodes. They form the first protective barriers for any infection. Right? So these tonsils are two in number, they are ovoid in shape and they are present in the oropharynx, the lateral aspect of the oropharynx. There are two surfaces, a medial surface and a lateral surface, and two poles, a superior pole and an inferior pole. Now when you go to the histology aspects of it, it's lined by what is called as a non-keratinized squamous epithelium, and that dips into the tonsillar tissue, which is called as the crypts of the tonsillar tissue. As the crypts of the tonsillar tissue, there are about 12 to 15 of such crypts. One is a very large crypt, which is called as the intratonsillar crypt of magna, And the tonsil is nicely covered by a capsule, and that is the important thing there. And in between the capsule and the pharyngeal wall, you have got nice loose area tissue, which helps us in dissecting the tonsil. Loose area tissue is important in there. It gives us a very good plane when you are removing a tonsil. There is something called what is called the bend of a tonsil. What do I mean by bend of tonsil? From the medial to lateral side, the bend is formed by the pharyngo-basilar fascia. Superior constrictor muscle of the pharynx, a buccopharyngeal fascia, and paratonsillar veins. These veins are important that they can produce severe hemorrhage by doing a tonsillation. They go and join the pharyngeal plexus of vein. And you also have what is called as a tonsillar artery, which is a branch of the facial artery. And you know the facial artery is a branch of the external carotid artery. And you also have the posterior digastric, also forms the bed of the tonsils. Then you have got upper pole and a lower pole of the tonsil. Upper pole and lower pole of the tonsil. And most importantly, the tonsils are very nicely supplied with blood vessels. And the various branches that supply to the tonsil is the tonsillar branch of the facial artery, the ascending pharyngeal artery, the ascending palatine artery, the dorsal lingual branch of the lingual artery, and then you also have a descending palatine artery. So tonsil is well supplied with so many blood vessels. And the venous vein, as discussed earlier, is the paratonsillar vein, which go and join the pharyngeal plexus of vein. When the lymphatic vein go, yes, definitely from the lymphatic, we go to the upper deep cervical group of lymph nodes and the jugulo-digastric group of lymph nodes. And the commonest infection which the tonsils are afflicted with is what's called as a tonsillitis, inflammation of the tonsils. A tonsillitis. It can be. Let us discuss first about the acute tonsillitis. The acute tonsillitis. Now, what do I mean by acute? That is rapid infection, afflicting mostly the school-going children. There are four types depending upon the involvement of the various tissues in the tonsils. Now, you have A, is it involving the surface epithelium of the tonsil? Or is it involving the crypts of the tonsil? Or is it involving the lymphoid tissue? That's the most important thing. Depending upon that, we have got a type 1, which is an acute catarrhal tonsillitis. By catarrhal, I mean it comes in seasons. It's called as spring catarrh. So here the viral element is the most important thing which forms the catarrhal tonsillitis. Then you have got acute follicular tonsillitis. Involvement in the follicles, acute follicular tonsillitis. Acute parenchymatous tonsillitis. The whole of the tonsils is called acute parenchymatous tonsillitis and acute membranous tonsillitis. The type 4 is acute membranous tonsillitis. And what is the etiology? Especially the school-going children are involved in this. And then, most importantly, the organism which is responsible for this is beta hemolytic staphylococcus, and a pneumococcus organism. Mind you, underline the beta hemolytic staphylococcus, which is also causation of the rheumatic fever. Now, symptoms of this will be a sore throat, and difficulty in swallowing, fever with or without chills and dryness, depending upon the severity of infection, and earache. Then you have also what's called other constitutional symptoms like a headache, abdominal pain, because the mesenteric lymph nodes can also be involved. The mesenteric lymph nodes involved, thereby increasing severe abdominal pain. Then when you clinically examine, definitely the child will have severe fetid odor, that is called as a halitosis. That means the foul smell emanating from the mouth of the child. And most importantly, the tonsils are covered by yellowish specks, yellowish spots, and you can also have a membranous type of tonsillitis. And the tonsils, definitely when you look at it, they are enlarged and congested, inflamed and red. Right? The treatment for this is a bed rest alone and increased fluid intake of these children. Analysis can be given. Analysis is safe to the children. So paramount importance. There's so many analyses. I don't want to elaborate. I don't want to elaborate. I want analysis to be choosy with your analysis. Then you give them antibiotics. Most commonly, what I do is I give a dose of erythromycin or a oxychloroquine for this period. And complications for this. So if you don't treat this thing properly, it can go on into what is called a chronic tonsillitis. It can go on into chronic tonsillitis. Or it can go on into a peritonsillar abscess. Abscess is a cavity containing pus. It can go into a peritonsillar abscess, a parapharyngeal abscess, and a cervical abscess in the neck. All these things are the complications. As also, it can produce infections in the ear. It can produce acute otitis media. Rheumatic fever. It produces rheumatic fever. As you know, I have already told in my earlier classes, it's not my domain, but the physicians will be able to tell you. Rheumatic fever licks the joints, but definitely bites the heart. Acute glomerulonephritis and subacute bacterial endocarditis. Now, going to the chronic tonsillitis, right? This is again when the acute tonsillitis is not properly treated, it doesn't get resolved and can proceed into what is called the chronic tonsillitis. Along with this patient, we also have a chronic sinusitis. So, what are the various types of chronic tonsillitis? One is a chronic follicular tonsillitis. Another is a chronic parenchymatous tonsillitis. And we also have a chronic fibroid tonsillitis. Various clinical features of this again, the recurrent sore throat, and chronic throat irritation. Again, same putrid smell, halitosis will be there, and thick speech. They have a thick speech, what's called a staccato speech, a thick speech, and difficulty in swallowing, dysphagia, and difficulty in breathing. And most importantly, when you clinically examine, objective signs, when you clinically examine, there will be congestion at the anterior and posterior pillars of the tonsils, and enlargement of the bibliodigastric loop of lymph nodes can be seen. Treatment is again conservative and treatment, antibiotics, analysis. After some time, not surprising, always you must go ahead and do what is called the tonsillectomy. You remove the tonsils, tonsillectomy. So what are all the complications of a chronic tonsillitis? Number one is the peritonsillar abscess. Once again, that's also called as a quinsy. A peritonsillar abscess is also called as a quinsy, right? Those are the complications. Then you have got a parapharyngeal abscess. At the side of the pharynx, you get abscess. That's called the parapharyngeal abscess. And within the tonsils itself, you can get what is called as an intratonsillar abscess. Another time, tonsillolith. It's a stone in calcified tonsillolith. And tonsillar cyst also can occur. And this focus of infection can lead to rheumatic fever and acute glomerular for this stage. Right? I think that.
10 minutes. 10 minutes.
10 minutes, right. Then we go into the next important topic, which is the quinsy. Quinsy. This is called the quinsy, what I earlier told. Another name, synonym. See, synonyms can also be asked as a question for you. So, quinsy can also be called as a peritonsillar abscess. Peritonsillar abscess, that is collection of pus in the peritonsillar space. Collection of pus in the peritonsillar, where that means between the capsule of the tonsil and the superior constrictor of the muscle. And most importantly, what is happening is this as a consequence of a chronic tonsillitis or acute tonsillitis, one can have a quinsy. Or it can be a de novo presentation also. That means without any previous infection, it can occur. De novo presentation of tonsils can also occur. Then, most importantly, the streptococcus and the staphylococcus are the incriminating organisms which are involved in this. And how does this happen? Just one of the crypts get inflamed. That can get what is the of pus inside the inflamed crypt. And the crypts keep on getting inflamed, thereby producing what is called an intratonsillar abscess. And that intratonsillar abscess, I said, is nicely encapsulated. It bursts through the capsule and goes through what is called the peritonsillitis. And that peritonsillitis will lead to what is called the peritonsillar abscess. Will lead to what is called the peritonsillar abscess. What are all the clinical features? So they have general clinical features. When we examine, they are severe high fever, the chills and dryness, the malaise will be there, the body aches will be there, nausea will be there, constipation. When you locally examine, they have severe throat pain. They complain of throat pain. Odynophagia, that means painful swallowing, that's odynophagia. And foul breath, they can definitely have a foul breath, most importantly. And poor oral hygiene. And trismus, yes. What do I mean by trismus? Inability to open the mouth is called as a, goes like this. Inability to open, most important cause in our country is again tetanus is the important cause. Trismus, what are the differentiating diseases? Is a quinsy or acute tonsillitis also they be having severe trismus. The examinations, the pillars of the tonsils will be congested and uvula may be shifted to the opposite side. Uvula may be shifted to the opposite side. And you can see neutropillar discharge coming out of the tonsils. And the patient's neck may be bent to the opposite sides. That is called as a torticollis. That is called as a torticollis. T-O-L-L-I-S. When we are head towards the opposite torticollis. And here again, the treatment is conservative diagnosis, hospitalization, intravenous fluid, intravenous antibiotic, and most importantly, oral hygiene. And most important thing is incision and draining of the pus. Incision and draining of the pus. And after 4 to 5 months, you do what is called as an interval tonsillectomy. Interval tonsillectomy. What are the complications of this? Parapharyngeal abscess can occur. Parapharyngeal abscess, laryngeal edema of the larynx can occur. Then they can go on to what is called as a septicemia, a lung abscess, a myocarditis, and glomerulonephritis. These are all the complications of it.